All right, we're going to go ahead and get started. Good evening, everyone. Thank you for attending this month's complimentary webinar hosted by the American Academy of Craniofacial Pain. Today's webinar is Ehlers-Danlos Syndrome, or EDS, and TMD, Treatment for Your Patients, presented by Dr. John Mitakides and moderated by Dr. Michael Hayes. Attendees are encouraged to submit questions using the chat box located to the right of the screen. Questions will be addressed throughout the presentation with a longer Q&A session at the end. Everyone should expect to receive an email with a recording of this presentation within 2 to 3 business days. Looking for more learning opportunities? Continue to sign up for these monthly live webinars and other continuing education at aacfp.org. You can also look forward to webinar recordings on our YouTube channel or keep up with the latest from AACP by following us on Facebook, LinkedIn, and Twitter. We are excited to offer the Orofacial Pain Specialty Law Review with Dr. Frank Record this Halloween. It is a must-take mini course covering the full legal history of orofacial pain as a specialty, as well as how the recent ruling by the ADA of orofacial pain as dentistry 12 specialty can affect your practice. You can sign up online at aacfp.org/legal20. And if you're in the Chicago area, don't miss the opportunity to learn live in person on November 6th and 7th with Dr. Milton J. Bliss. Our moderator this evening is Dr. Michael Hayes. He is a native of Nebraska. He graduated from the University of Nebraska College of Dentistry in 1979. He is a diplomat of the American Board of Craniofacial Pain and the American Board of Craniofacial Dental Sleep Medicine. He serves as the director on 4 dental boards, and we are very excited to have him join us. Welcome, Dr. Hayes.
Thank you. It's my pleasure to introduce tonight our speaker, Dr. John Mitakides. He is the founder of the TMJ Treatment Center. He is a specialist acknowledged by the ADA in the fields of craniofacial and orofacial pain. He is a diplomate of the American Board of Craniofacial Pain and Orofacial Pain. He is a member of the International Ehlers-Danlos Medical Board. He is a diplomate of the American Board of Dental Sleep Medicine and on the board of Chronic Pain Partners. He is licensed to practice in Ohio, Maryland, Texas, and Indiana. He's on the staff of the Greater Baltimore Medical Center, Cincinnati Children's Medical Center, Kettering Memorial Hospital. He has lectured and treated TMJ, craniofacial pain, migraine, trigeminal neuralgias, tic douloureux, and other headache and neck pains for over 45 years all over the world. He has practiced with Sir Rodney Graham in London, England, and is on the courtesy staff of St. John and St. Elizabeth Hospitals in London, England. He's on YouTube and has published in multiple publications and books. Dr. Mitakides, take it away.
Well, hello everyone. Thanks for coming tonight. And tonight we're going to have a little floss over as per how TMJ, hypermobility, and the Ehlers-Danlos syndrome all blend together. Now, the one thing that we know about is that when you talk about Ehlers-Danlos and you talk about TMJ, well, the TMJ patient does not have to have Ehlers-Danlos syndrome, but most Ehlers-Danlos syndrome patients do have TMJ. We actually did a study in my office. We had 200 EDS patients, Ehlers-Danlos patients. 195 of those had some type of TMJ or TMJ problem. So at that point, it's interesting to know that if you actually see a EDS patient, you can probably bet they have a TMJ problem. Okay. All righty. So let's talk about Ehlers-Danlos and what it is. Ehlers-Danlos is a syndrome that has a hereditary collagenous situation that is caused by genomes and sites that compromise the integrity of all the tissues in the body. Now, everyone's a little bit different. Everybody has tissues that are affected in ways that, like the Cirque du Soleil kids that can put their legs behind their heads, or dislocate their elbows or their knees, or sometimes they can do that, sometimes nothing happens. Sometimes they can take their fingers and roll them all the way back, like in this picture. Sometimes they can actually dislocate their fingers, their knees. Sometimes nothing happens, but sometimes also two EDS families will get together. Neither syndrome is either place, but when they get married, all of a sudden hypermobility is there for the big time. Now, the classic genes for proteins that interact and process with collagen are the COL1A1, 1A2, 3A1, 5A1, 5A2, and the ADAMTS2 and the TMXB genes. These are the classic primary genes that affect the proteins and interact with the collagen. Now, when you're actually testing this to make sure what you have, there's the thing called the Beighton scale. And the Beighton scale basically is a clinical scale. There's 9 different syndrome situations where the elbows will dislocate, the knees will dislocate, you can hyperextend the arms, etc., etc. And there's 9 different sites. Now, if you really need to know where the sites are, biochemical and gene identification is the way to actually physically see where it is. Now, the thing that we found out is that in the last major meeting that we had, which was in Ghent, Belgium, we came up with 74 different gene sites. And we also came up with the fact that it affects 2 chromosomes, chromosome 13 and 15. And there's genetic alterations of the fibrillin and alterations of glycoproteins that form the elastic fibers of the collagen. And this is where the situation occurs. Now, there's different types of EDS patients, the most common of which are the classic EDS, the hyper EDS, the vascular EDS, but there's also 7 to 12 different types of EDS depending on what the situation is. And here's the Beighton scale that we talked about. Okay, let's go to the next one. Okay, now we all know what TMJ is and does. We know about the jaw opening, no deviations, no pain, no sounds, normal chewing and lateral motions of the condyles. But we all know what's not normal. Limited mouth openings, jaw deviations, joint noises, inability to chew or occlude, the headaches, the ear pain, limited cervical motion, and we're going to get into that quite a bit. Muscle spasms and aberrant oral history. Who in the family had a TMJ problem? Now, we also know the areas that cause pain. Now, we know that the synoviums, anterior, superior, and inferior, are actually the areas that actually cause the pain upon compression. We know that the temporomandibular joint ligament, which goes across the TM joint, will actually cause pain. And we all know the compression in the posterior laminate of the joint itself in the number 7 area, and retrodiscal tissue will cause pain. Now, there's some other ligaments that you don't really pay that much attention to. The lateral medial collateral ligaments hold the meniscus in place. Tanaka's ligament, which some people don't have an idea what that is on the medial surface of the condyle and stops the lateral motion of the condyle for dislocation. These are all areas that can actually cause pain and discomfort. Now, we're actually talking about muscles also that cause discomfort. We're talking about all the muscles of closure, the muscles of mastication, the temporalis major, internal pterygoid, the external pterygoid, and the superior and inferior head of the external pterygoids are what causes sharp pain when there's pain in the joint itself. Now, the running joke is the temporalis muscle acts to me like a big meter. If it's sore anteriorly behind the eye, it means the jaw is pulling forward. Middle above the ear means the patient is clenching. Above the ear and behind, it means the jaw is retreating. So you can usually tell where in that tenderness on that temporalis where the discomfort is being generated from. Now, there's other areas that the inferior border of the mandible and the anterior neck and suboccipital areas, the anterior belly of the digastric, the omohyoid, the superior pharyngeals and the pharyngeal constrictors, and the middle pharyngeal constrictors. All those are muscles that generate problems, and we're going to talk about the superior and middle pharyngeal constrictors and how they actually cause TMJ discomfort, popping and noise. Now, these are the muscles in the neck. We're going to talk about these two. These are the ones that maintain the head anteriorly and posteriorly. And again, the orthokinematics of the joint. We know that it's a cingulomorphoradial joint. We know that there's three-dimensional patterns of motion, the coronal, sagittal, and transverse motions. We know that the joints are synovial. We know that the centricalization, for most dentists, they maintain that the occlusion, the bite itself, is a centricalization. When if you're talking about joints, it's not a dental term, it's a synovial joint terminology term for the congruence of the joint surfaces for the proportional growth and development. Now, there are two statements here that are probably more important than anything you'll see in the last 5 or 6 x-rays, and that is the pre- and post-vertebral musculature that determine the jaw position. In other words, the position of the head, and that the craniomandibular rest position is a function of the mandibular rest position. So in other words, where the jaw sits, the head will sit. Where the vertebrae and the muscles sit determine the jaw position. So in other words, there's 2 to 3 different things that will maintain the jaw position and the craniomandibular position. And we're going to find out about that as we go on. Now, neurology, we all know about the neurology, and we all know about the trigeminal nerves. We all know that supraorbital above the eye, infraorbital below the eye, the V3, which is the mandibular sensory motor input to the jaw and the muscles in the anterior belly of the digastric. Keep in mind that the anterior belly of the digastric and the lateral rectus muscle, eye blurring, are all areas that are generated by the V3 area. Now, keep in mind that the trigeminal nerve actually sends branches to C2 in the neck and goes to L2 in the lower back, and that there are convergence and nociceptive mechanisms. The classic nociceptive mechanism is when there's pain in the lateral side of the neck, and it actually will generate pain in the temporal area. To actually explain that to you takes about 20 minutes, but that's a classic nociceptive pain. Convergence pain and pain that's generated in multiple areas. There are neural areas that will actually be confluent with one another and generate pain. That's another lecture into itself, but just let you know that happens. Now, CCI is cervical cranial instability. In other words, it's the stability of the head and neck, and it helps, and it actually causes the jaw to change its position. Pre- and post-vertebral musculature determines the jaw position, right there, number 3. And the cervical cranial rest position determines the mandibular rest position. So the more the head moves forward in the forward head posture, the more the jaw tends to protrude, okay? And keep in mind that for every 2 inches the head moves forward, the head posture doubles the weight of the head. So we actually have pain from ligaments, jaw position, and head position. And this is where the CCI comes in. Now, there's also ligaments, upper cervical ligament evaluation in the neck itself. And the major ligaments are the cruciate ligament. And if you're testing it, you can have the patient do the yes motion, up and down, okay? If you're checking the transverse ligament, it's the no ligaments, rotation side to side. And if you're checking the alar ligament, it's side and side, and when you move the head. Now, if the head is limited in motion and or there's discomfort or there's crepitus or motion, that means usually there is a vertebral displacement. The transverse ligament, the atlas, that's C1 testing. In other words, when you do the no ligament go side to side, if in fact the head doesn't go, it means the transverse or C1 is out of position. If you do the alar ligament side to side and the head movement is limited, that means C2 is limited and or out of position. There's again, trying to figure out where these are is fairly paramount to what we're going to find out here in a minute, to the actual jaw position. Now, keep in mind that if the spinous process of C2 does not move from side to side, don't touch the patient. It means the alar ligament is stretched or torn. It can actually cause damage to the cervical spine. Now, these are the ligaments. Here's the alar ligament, there's the transverse ligament, and there's the cruciform ligament. That's where these are in the neck themselves. Now, cervical cranial relationships, continue those. C2 is the animal that makes most of the relationships to the neck itself. And vertebral rotation of C2 is important. Now we're going to jump to the next one, and this is probably the most important X-ray in this lecture. Look at the X-ray on the left, and it's the one that shows that the DENS process of C2 is in the middle. The spacing is equal from side to side, and if you look at the occlusal heights of the molars, you can see they're fairly even. If you look at the one in the center, the X-ray in the center, and you see the arrow, that's rotation of the cervical vertebrae to the right, okay? But when it moves to the right, it'll actually cause torsion of the mandible. So if you look at the height of the molars, left and right side, you'll see on the right side how high it is in apposition to the left-hand side. On the patient, the right-hand side is low, left-hand side is high. Same thing happens if the jaw is rotated in the opposite direction and the vertebrae are rotated. So this vertebrae is rotated to the left, you see the space increases, and if it's maintained in that position on the patient, the left side is below height and the right side is above height. Believe it or not, this will actually generate popping of the joint itself, because what it does is it actually compresses or decompresses or rotates the condyle in the joint. And this is actually very important. Number one, if you understand how this works, it will limit the amount of surgeries that are actually done on the joint to reduce the popping and cracking, because in fact, it's not truly the joint, it's actually the position of the vertebrae. When you actually reposition these vertebrae, the popping and the cracking will go away. Now, this is just a picture, just a little fill-in, rotation of the atlas, and that's the C1 and the DENS. And this is, if you look back behind the spring, you'll see the anterior arch of the first cervical vertebrae. That's where the pills get stuck when you go to swallow. So when C1 is rotated anteriorly because of the rotation of C2, it'll actually move forward, and that'll actually make the pills actually get stuck when you go and try and swallow them. And that's the DENS from C2 going up into the anterior arch of C1. Okay, now we're going to talk a little bit about occipital neuralgia. Now, the occipital neuralgia is usually generated in two areas. Number one, the lesser occipital neuralgia is generated between the skull and C1, and that's the area that goes behind your ears for discomfort. The greater occipital neuralgia is actually generated between C1 and C2, and what happens is it'll actually cause compression to that nerve that goes to the occipital muscle in the back of your head, it goes to the vertex on the top of your head, and will go to the frontal area above your eye. And believe it or not, when it actually goes into that frontalis muscle, it'll cause compression on V1, and it'll cause the trigeminal compression. And this is the discomfort that'll go around the eye, behind the eye, and it'll actually mimic a migraine. Now, other problems that generate themselves. Number one, when you look at the TMJ itself, you look at the hyoid bone, and when you look at an EDS patient, the hyoid bone in the throat itself is very loose and can actually move around a lot. So if the hyoid bone is positioned from maximum clenching, it'll actually cause what they call an anterior open bite, or the hyoid bone protrusion can cause airway constriction. Okay. Now, if you talk about the elevator muscles, you get a patient that clenches a lot. If they clench a lot, the short upper lip will be produced. A last loss of the Cupid's bow will be noted. In other words, the upper lip and the Cupid's bow. Retro inclined profile is fairly noted, with the jaw being protruded. And the thing that increases most of the trouble is the superior and middle pharyngeal constrictors. In other words, the release of these two constrictors from clenching can restore 50% of the muscle position of the airway volume. So if you can stop the patient from clenching, you actually will relax the superior and pharyngeal constrictor muscles, increase the airway volume, the patient will actually sleep better. Now, the oral appliance with increased vertical will actually increase the amount of clenching that the patient does. And what we find out is that the softer the appliance is, again, it'll increase the amount of clenching. Again, we're talking about forward head posture. Every 2 inches, we talked about doubles the weight. And we're talking about cervical angulation. Normal angulation is 101 degrees. All the vertebrae will be anterior to it. But the more anterior head position you have, the less the patient can lift their head, and it's fairly easy to diagnose. Torticollis, we all know about, hopefully. Torticollis has to do with the C6 and C7 vertebrae being rotated, and that's actually, when you look at the patient, the neck will be almost perfectly straight, and the sternocleidomastoids from the mastoid process to the suprasternal notch will be actually straight as a board, and that's tightening and pain in the neck itself. Again, that pain in the SCMs, the sternocleidomastoids, will actually refer to the lateral side of the head up in the temporal area. So if you have pain there, that's another source for it. Here with the upper cervical evaluation, we just talked about that. Now, there's another system that happens called dysautonomia. Okay, and the dysautonomia itself are the structures that provide the autonomic nervous system actions. Okay, so what happens is there is an area, believe it or not, in the rear of your throat that has a few structures. Okay, now keep in mind, we're going to talk about those in a minute, but dysautonomia, POTS is dysautonomia, but let's go to the few structures that are in the rear of the throat. Number one, the mentalis muscle is a muscle in the anterior lip. It goes to the orbicularosaurus, which goes to the buccinator, which goes to the orbicularosaurus. Okay, here it is. And what happens? The middle pharyngeal constrictor muscle basically goes from the chin and it goes to the basion, and it affects C4. So we had the middle pharyngeal constrictor. So the superior pharyngeal constrictor will go to C1, 2, and 3, and the middle pharyngeal constrictor will go to C4. And what happens is, if you actually take your jaw and put it forward, you can actually feel the pull in your neck. And then so what happens is the constriction of that middle pharyngeal constrictor muscle, due to clenching, will actually pull the vertebrae forward, decompress the pharyngeal airway, and will actually cause a little compression of a few items. And those items are these: the vagus nerve, the accessory nerve, the hypoglossal nerve, the sympathetic trunk, the alar fascia, the glossopharyngeal nerve, the internal carotid artery, the facial nerve, and both pharyngeal constrictors will actually cause that, and that will cut down the airway. Interesting. So if you have patients whose GI tract is acting up, their heart rate is aberrant, their breathing is aberrant, they can actually be all attributed to possibly a dysautonomia, which this is. Now, there's one other syndrome that we're going to go through, and it's called the cervical myofascial pain syndrome. And this is, believe it or not, this lecture we actually give to neurosurgeons because of Chiari surgery. Now, if we don't know what Chiari surgery is, basically Chiari is when the brainstem starts to be constricted by the skull's osseous processes in the base of the skull. So what that does is it'll give areas of numbness or paralysis in the body as they move down. So when they do the surgery to cure the Chiari, they'll actually relieve the areas in the skull and fixate them with titanium and screws so nothing moves. But the one thing that helps that surgery is figuring out the cervical myofascial pain syndrome. So basically, what happens is that the mandibular positional change will cause the superior and middle pharyngeal constrictor muscles and the tension they affect on the cervical plane, and they will cause the upper cervical vertebrae 1 and 2 to actually be torsioned. When a vertebrae avulse, there are a couple things that happen. The levator scapulae muscle, when C2 moves, will actually go into spasm. And that levator scapulae muscle goes from the C2 area to C7, and then it goes underneath the shoulder blade and actually cause tension. It's the traditional, I call, knife under the shoulder blade pain. And then the levator scapulae muscle will cause discomfort. There it is. Now, another thing that happens is the lateral tubercle prominence of C1 will actually move laterally because of the rotation of C2 that causes the levator scapulae pain. And the C1 vertebrae will actually move forward, and that's what you'll actually feel underneath the ear itself. Behind the jaw, there'll be a prominence there. And that's where the SCM muscle, believe it or not, will cause spasms down the left side of the neck. And that's one there, right there. And then the longus colli muscle will become tender to the touch, and it'll become malpositioned to the vertebrae in the anterior aspect. Another thing that happens is the greater occipital nerve in the back of the head and the lesser occipital nerve behind the ear will actually come forward, and it will cause compression, which will cause pain in the back of the head, the vertex and the aponeurosis vertically, push on the frontalis, just like we talked about before, and push on the trigeminal nerve above the eye, around the eye, behind the eye, and it'll actually feel like sinuses. Now, the good news about this is, here it is the aponeurosis going over the top of the head and how the greater occipital nerve actually travels. So basically what happens is when you relieve, number one, the C2 positional torsion, C1 positioning, you'll relieve the levator pain, the SCM pain, the longus colli pain, the pain over the top of the head, pain over and behind the eyes. All this discomfort can actually be interpreted as headache or head pain. When you relieve all that, the Chiari surgery that's done tends to be superiorly more effective. And that's one of those important things that a person should think about when, in fact, you're talking about this, the Chiari surgery itself. Now, so in conclusion, the upper TMJ and cervical stability are fairly important. Most people assume that the TMJ, the world ends at the tonsillar pillars. There's no other situation. When in fact, when you examine a patient, you should examine the neck, the upper trapezius areas, the areas in between the shoulder blades. You should examine the lateral neck, anterior, and laterally, and all head pain that you would normally examine. Keep in mind that the position of the vertebrae dictate, again, the position of the TMJ and cause the popping and the cracking. Now, I know I've gone through this 100 miles an hour, but I think we might be okay for a few questions. Michael?
Well, so far, I don't see that anybody's sent any questions on the chat. I do have some. Dr. Angie Tenholder was kind enough to, she has some experience with EDS, and she sent me some questions. What other symptoms are often found in patients with EDS other than joint stability?
Joint stability. Well, you have inflammation, pain. You have areas of ligaments, tendons, etc., that cause discomfort. You've got the synovial compression in the joints. There's just a boatload of different things that can actually happen. But Angie has asked me this before. So she's good at it.
Yeah. Like I say, she's very knowledgeable about this. Yeah. And I'm glad that she was kind enough to share some of these with me. Are there nutritional recommendations that can help EDS patients improve their quality of life?
Well, basically, believe it or not, the general nutrition patterns are fairly normal, but believe it or not, potassium will help this. It'll help keep the muscle spasms down and keep the head pain when you wake up in the morning. You've been clenching your jaws all night. What happens is that those muscles will go into spasm. And then when you wake up in the morning, you've got just basically an untenable headache. So it's not fun.
Yeah.
So potassium.
Yeah. I think we all see that quite a bit. A question I would have is how are there treatment protocols that are different, that you find that are different for EDS patients than, let's say, whatever a normal TMJ patient with, or a patient without EDS? Are there things that you do differently?
There are quite a few things that we do differently. Now, number one, especially with the EDS patient, I get a lot of patients from out of town. I get them from Germany. I get them from Singapore. I get them from all over the world too. But then what we usually do is we treat them in a four-day group. So the first day we examine them. The second day we treat them. Third day we let them cook. Fourth day we check them. Okay. But what happens is that what we were talking about, the position of the vertebrae in the neck. We were talking about the position and the compression of the PTM joint itself, and or the tissues in the gum tissue and other structures. But the one thing you find out is with a true EDS patient, they can actually compress the teeth, compress the periodontal structures, actually seat the condyles so far into the joint that it actually causes compression of the synovium themselves and the nerves in the back of the joint. So what tends to happen is we suspend them, number one, and number two, we actually rotate and decrease the amount of compression in the cervical spine and the neck. And it may sound a little pompous, but we usually have about a 89 to 90% relief of most of the pain symptoms after 4 days by doing the procedures.
So what procedures are you doing for the neck in particular?
Okay. Well, unfortunately, I'd have to show you how to do it. It's a physical therapy move, okay? But what happens is there's a rotational move that we actually rotate the vertebrae back in the position, okay? And what they'll do is we actually show the patient how to do this. So when they actually start to get the head pain or anything that would actually act like a migraine, they can actually relieve it themselves. And it tends to work very well. After about 4 appointments, we usually see the patient at 6 months to a year after that.
So are you treating them with splint therapy as well as the cervical manipulation?
We're using splint therapy. We're doing an anterior positioning appliance with a pivotal edge on it. And we actually don't do any occlusal adjusting until we've got them a year down the line. In other words, they're comfortable for that amount of time because we don't want to do something that's irreversible.
John, do you see increase in airway sleep disordered breathing in Ehlers-Danlos patients compared to the other population of patients?
Of course you do, because the tissues aren't as strong as you would like them to be. Plus the fact that they tend to rotate and the anterior head posture because they don't have the strength that they would normally have. The one of the big things that EDS patients have is a thing called POTS, and we talked about that. And it was positional orthostatic tachycardia. So in other words, the veins themselves will actually tend to collapse. In other words, the blood will pool in their legs. And it's the same thing with the arteries in the neck and the musculature. Everything tends to collapse. And that forward head posture we were talking about, that 2-inch anterior posture will actually help close up that airway. Therefore, the sleep problem gets to be fairly prominent.
At what age is EDS typically diagnosed?
Well, the youngest I've ever seen is 3 years. The oldest I've diagnosed is about 92. Okay. The kids, the 3 years, usually have something fairly distinct in jaw positioning. But the ones that are most prevalent with this, believe it or not, are pubescent females. They are probably the ones that get attacked the most with this because the estrogen tends to hypermobile, make their tissues hypermobile,
right,
and actually affects them the most. Yeah, they will. It's not unusual to see a 13-year-old in a wheelchair in my office.
Mm-hmm.
Yeah.
Now, this obviously will affect facial growth. What do you recommend, or what are you doing in terms of facial growth? Are you treating the postural issues, the forward head posture, doing anything to encourage mandibular growth, forward growth of the mandible?
The answer is yes, we do that. We do anterior positioning, okay, and then we use head positioning exercises, PT, chin tucks, everything that you would imagine that you would do to retract and retrude the head, to straighten the spine, to actually set the jaw in the correct position, and to make sure that the neck and the jaw itself is not dislocated and or limited in motion.
I think a lot of people. Do you look at the position of the maxilla as well as the mandible?
Absolutely. And there are some people that we'll actually recommend them to have surgery, but there aren't many. Okay, because the one thing that we found out is that the surgeries do not tend to hold up well.
Yeah, I know they
So
don't.
the more, yeah, unfortunately, yeah. Okay.
I haven't seen any questions come up from anybody else. Could you talk a little bit about more about EDS and dysautonomia?
Sure. The dysautonomia is in fact now the dysautonomia, the way I describe it, has to do with compression of all those structures, glossopharyngeal nerve, the vagus nerve, all those autonomic nerves in the rear of the throat. Now I have a friend in Tarrytown, New York, and she does more of the cell structure itself, and she actually does that a lot. So if in fact we don't have anything in that thing, we actually move you up to Tarrytown, New York, and have Ann, her name is Ann Maitland, have her actually examine you, because she's the queen of dysautonomia. So we do mechanical, she does the magic, quote unquote.
Mm-hmm.
Yeah.
So are there particular physical therapists, chiropractors, people that do body work that you work with in particular, or any particular type of training that they've had?
Well, usually what we do is we usually tend to show the people how to do it themselves. Now there is a nuntial chiropractors. They're low and slow. Okay, a lot of times they'll help. Okay, but your high speed, I don't know whether you see it or not, but do you know what a pontus pontificus is?
Not necessarily. It is, no.
Basically it's an arch of bone that forms over the top of the vertebral arteries.
Oh yes, I have that myself. Yes.
And what? Yeah. And what happens if you get the chiropractors to do the high speed adjustment? I've heard of more than one person with a torn vertebral artery going home bleeding out.
And strokes. And strokes.
Yeah,
I've seen that too.
One. Yeah. So we don't.
Yes.
I don't. So that'd be, like I said, the nuntial chiropractor is the only one I would tend to recommend.
Yes, I look for those on the CBCT and recommend patients don't ever let a chiropractor do the rapid
touch them. Yeah, movements. You got it.
Yeah. Another question from Angie is what?
Sorry, Dr. Host, do you see the question again in the chat area?
No, I don't. Is there?
Okay, so the first one is, let me see. Is this a Mendelian genetic inheritance findings where both parents must have a recessive gene in which 25% of the offspring may have it?
The answer is yes. You'd be amazed. Some people don't have them all. Some people may have a little bit. There is no specific pattern for this, but the ones that do have it, the classic is I've got one family in Fort Wayne, Indiana. Okay. And there's five kids, two of which looks like nothing ever happened to them. Three of which look like they've got run over by trains. I mean, they're on walkers, they're in wheelchairs, and it's almost impossible to imagine where the weaknesses are and what is happening with them. But when I see them, I always see all five of them at the same time to make sure that nothing's happening to it. And their mother brings them just like clockwork, about 3 times a year. But that's pretty common. And so what was your question? I lost it.
Yeah, so is the Mendelian genetic inheritance findings where both parents must have a recessive gene in which 25% of the offspring may have it?
Mm-hmm. Yeah, that's not unusual. But I've seen more than one have it. Yeah. Go ahead.
Just the next question, how do you manage these cases?
Okay. So number one, there's nothing you can do to make the case. You can actually support the patient, but you cannot fix the patient. Okay. So number one, you go into situations where you talk about compression clothing, you talk about PT work, you talk about head positioning, you talk about a lot of things that you would actually think to support the patient. And you have to actually be able to know and understand what's happening with the patient. The one thing that you'll find out is that if you understand what's going on, you'll be the king or the queen of what's going on, because patients usually cannot find anybody that understands what's going on with an EDS patient. So if you understand it and can help them support, it's just the most wonderful thing that you'll ever do for them.
I can see the questions now in the chat. I found the right button. Edmund Liam has a good question. In cases where jaw locking and clicking are not manageable, do you use prolotherapy?
The answer is sometimes. If you're talking about an EDS patient, though, we'll actually go into the anterior joint posture. Okay. If in fact you've never done this, if you can actually move the jaw down out of the joint and put it to the point where the joint is supported but in an anterior position, you can usually get rid of the joint popping. Okay. And I probably have not gotten rid of one in about 15 years. It's a pretty common area for me. Prolotherapy, sometimes, not a big sales deal for me.
Okay. And Paro David has a question. Would the sleep appliance be contraindicated in any of these patients?
A sleep appliance, not necessarily, but you got to keep in mind too that the thicker appliance that you put into it, the more they tend to clench. The more they tend to clench, it tends to take the superior constrictors and closes them up. Okay, so what it's going to do is not only will it open the airway, but it'll help close it from the rear of the throat. Okay, and that's what most people don't realize. So if you're going to do a sleep appliance, move the jaw anteriorly till you actually get the physical pop done, get it out of the way, and then set your position. But keep in mind, don't make it too thick, don't make it soft. Okay.
Very good.
Go ahead.
Well, Amparo also asked if there are any, do you treat with alpha appliances at all?
What do you do? What do you define an alpha appliance?
Well, it's an advanced light wire functional, any of the light wire appliances.
No, I don't use them at all.
Okay.
Don't use them at all.
Quite a few people asked about, and I think I maybe had already covered this, do you co-manage these cases with chiropractors or neurosurgeons, PT? I think you kind of alluded to that before.
Well, I believe it or not, I use neurosurgeons a lot because I end up seeing a lot of businesses in the neck. You know, like I say, we were talking about the pompous. We'll actually show compression. We actually take a lateral head view and it with the neck and with the vertical compression. And that actually shows a lot of the problems with the neck. So I've got about 5 neurosurgeons that I work with in the area. You wouldn't think that I would, but I end up doing it.
Another question that's come up with several people is use of the low-level laser therapy. Do you use any of that?
We'll do cold laser. The answer is yes. And we tend to do it for the musculature in the neck and the shoulders and the posterior and anterior neck. The answer is yes.
Okay. What was the protocol you use for that?
Basically, we go with...
I mean, how often do you do it?
Well, basically, we'll do it 3 to 5 times a week. Okay. We do it with the length of the musculature itself. And what tends to happen is it'll actually tends to actually take the musculature and relax it. Now we do the same thing for people who play golf, and we do that for forearms also. So the answer is it does work. Works lots of different places.
Yeah, I know it does.
Yeah.
We have Ryan Hart has a question about do the less successful surgeries also include orthognathics of different types?
The answer is yes. Though, yeah, I'm not going to.
Do you tend to see relapse?
Hell, what I tend to, I tell you what, I tend to see breakdown. Okay, and I tend to see more discomfort involved with it than not. What tends to happen? We had one fella that this was back, I hate to say it's about 2007. Okay. They actually went in, did the condylar reduction, put in Zimmer condyles, and tried to actually maintain the patient without maintaining his clenching, et cetera, et cetera, et cetera. Needless to say, he blew the Zimmer condyle replacements out entirely. Okay, completely blew the screws out, blew the condyles out, and it turned out that this woman, who it actually was a woman they did it on, her woman and her husband was the coroner. How's that for fun? So we ended up doing actually a reduction. Actually took the condyles out that he did, and we actually suspended her, and we got actually tissue to build back in. We actually used some plasma tissue, and we actually got the tissue to actually physically build back in, and it worked on her.
I think we've covered most of the questions directly or indirectly. Somebody did ask, which laser do you use?
The cold laser.
Yes.
The one, yeah, cold laser. That's I got it from a guy in. Yeah, you can call me and I'll tell you who I got it from. But
Okay.
I got it from another dentist in Atlanta, and he actually sells them. So we got them from him.
Rita has Abdul Fattah has a good question. Botox. Do you use Botox at all? I think you and I have talked about this. I think you do.
I use both. Yeah, well, I use Botox a lot. I do. I'm the Ohio State Dental Board expert on Botox and facial fillers. Okay. So I do a lot of migraines. In fact, if I could fill up a bus every month, I could get that many people from the East Coast coming in. But again, it's the trick is, yes, I do use it a lot. And there's another, I'm going to throw this out just for fun. You know, the upper molars that people end up getting root canals on, extractions, and the pain is still there. That is, believe it or not,
see it all the time.
A middle superior alveolar nerve goes into spasm. So if you put 5 units of Botox right in the buccal, just above the tooth, but underneath the zygoma, the pain will go away for 6 months. It's that simple, and it's not the tooth.
Yeah.
It's actually the masseter that's causing the spasm.
Yeah.
And
do
like
you
I
recommend?
Said,
a couple other good questions here. Do you find benefits from PRP or PRF?
The answer is I don't use them, so I don't know. I don't even know what that is.
And well, it's the plasma rich protein.
The plasma.
It's used,
we do.
Yeah, the plasma.
Yeah, we do use
I know
that.
it's used a lot in joints.
Yeah, we use it on that woman that had the
protein-rich plasma.
condyles cut off. Yeah. And they actually, the tissue actually filled back in. It was actually pretty impressive. Yeah. Like I say, her husband was the coroner, and he actually talked us into using that. It was funny, but yeah.
Rita's got another good question. Do you recommend collagen as a supplement?
Collagen, it's usable. Yes, we can do that. Go ahead.
Nutritionally, how does that work? I mean, how does that work? I mean, is the collagen passed through and absorbed as collagen, or is it broken down when it goes through the GI?
It's broken down.
I think it's broken down.
Protein.
Yeah,
the protein.
Yeah.
Yeah, the proteins are picked up. Yeah. And it's about that simple.
And are they used effectively that way?
Sometimes they are, sometimes they are. It depends on the GI tract. You have somebody that's got GI problems, you don't have a good time with that stuff. In fact, it'll actually give you gut problems.
I'm looking through the questions here, seeing if we've covered most of everything. I think I apologize if I've missed anything for people here. I guess I'd have to ask Katie where we are on time, and
we have about 2 minutes left. If there are any last questions.
Amparo David has a question. Do you teach your protocol?
Yes, I do. I do it. I'm in the process of writing a book right now too, so we're gonna throw that out. The thing that I do teach is the cervical action protocol, and that once you learn how to do that, it makes all the difference in the world. I guarantee that once you actually start using that protocol, you'll use almost nothing but that protocol, once you actually physically do it. I have a friend of mine in Santiago, Chile, and he and I developed this protocol for rotating the cervical vertebrae, and it makes all the difference in the world. I have patients that that come into me every 6 months for me to put their neck back in. And when they do that, they get up, they're feeling wonderful, the headaches are gone. Truthfully, I can actually get rid of a cervical junction migraine in about 5 minutes by using that protocol. I mean, it's just, once you learn how to do it, it's magic. It really is.
All right. This is probably a random question, but do you find that there are any problems with the dental boards allowing you to do these types of things?
Nope, there's no problem at all. Nope.
Good.
Nope, not at all. And in fact, I have a couple of the inspectors come in. I do them.
That's always good. The friend in Chile, is that Rockabato?
Mariano, absolutely.
Yeah. I figured that was. Yeah. Well, we have people wanting to know where your courses are, including me. And another question is, do you allow doctors to come observe in your clinic?
Yes, we do. Yes, we do it all the time. And so I'll tell you what, we since this COVID thing, my schedule has been sort of screwed up. Wait till I get up, put the new schedule together, and then I'll actually put it up on the AACP website so everybody knows who, what, when, where, and how.
That would be wonderful. We'd all appreciate that. I think you've piqued a lot of people's interest, including mine.
Okay. All right.
Because I can relate to a lot of things that you're talking about. We see this all the time. It'd be nice to have a few more arrows in the quiver.
You got it. All right.
Okay. I think I hope I've covered everybody's questions. And Carlos has said a great presentation, John. Looking forward to any further courses you will give on this, and I will echo that comment. Anything else? Or you have any closing remarks you'd like to add?
Well, it's a pleasure talking to all of you. Michael, it's good to see you as always. Yeah, Carlos,
See you.
singing and dancing. Okay, but it's good talking to all of you. And Angie, I'll see you next time.
Okay.
Perfect.
All righty.
All right.
Well,
Thank you very much.
everyone. This was a wonderful presentation. Thank you for joining us. We will be holding our next monthly webinar on November 18th at 7 p.m. Central, and we will have Dr. Wade Cooper. So stay tuned for more information on that, and thank you again. Have a great evening.
Thank you,
Yeah.
John.
Okay. Michael.